Good afternoon, everyone. Welcome to our first general membership luncheon since last February, since COVID hit us. And we decided to combine today's program, our luncheon program, with our twice postponed Cancer Care Symposium and present just the keynote session today as part of our general membership luncheon program. We decided that this was the wise decision because cancer is such a complex and costly and confusing disease, and it takes many forms and it impacts all aspects of the patient's life. Cancer is also very prevalent, with approximately 1.8 million new cases per year, and with an average cost of about $150,000, which is 4 times higher than treatment for other common health conditions. And some new cancer treatments exceed $1 million. So cancer absolutely requires coordination across the entire healthcare spectrum. Employers are searching for effective strategies to ensure access to high quality coordinated cancer care and for their employees, but at an affordable cost. They also want to support their employees on the very heartrending cancer care journey. So this, the Cancer Care Symposium is designed to help employers build a comprehensive, seamless benefit strategy that addresses the 3 key stages of the cancer care journey, starting with prevention and early detection. Stage 2 is the actual care coordination process during treatment. And then, since most cancer, or many cancers become chronic or can be managed chronically, the 3rd stage is the caregiving and survivorship and return to work. So we will be presenting 3 workshops on the 3 stages that I just mentioned. They will be on October 15th will be workshop 1 and 2. On November 17th will be workshop 3. And your registration for today's program includes registration for all 3 workshops as well. So we hope that you stay engaged with this topic. It's important, and I think that the results will be a much better understanding of how we can manage the cancer care journey effectively and also support employees going through that process. I want to recognize all of our sponsors today, and I'm grateful to Genentech, AbbVie, Boehringer Ingelheim, Cancer Treatment Centers of America, Meadows Mental Health Policy Institute, Merck, Novo Nordisk, Pfizer, Caraloop, Cigna, and Texas Oncology. And for each of the programs in the Cancer Care Symposium, we'll be having a sponsor spotlight for each one. But let me go back to, we'll talk about Genentech first. So I'll go ahead and introduce Tiffany Miley with Genentech. You've got a 3-minute sponsor showcase. Tell us a little bit about Genentech.
Okay. So Genentech is, a very diverse company. We're really excited to be partnering with you guys today. And so as it relates to cancer, we have a broad therapy. We cover many therapeutic areas across our cancer portfolio. And so really our vision is to aim to partner across the healthcare system to deliver ever better health outcomes for patients while lowering overall healthcare costs. Next slide. And so, Marianne, as you mentioned earlier, early detection is really important. And so we have a number of resources to advance lung cancer screening. And so we have what's called a Think Screen No campaign. And this is a portfolio of resources that are available, for all the health systems that we partner with, for screening and outreach. And our goal is to really improve screening efforts for high-risk individuals, as well as disadvantaged populations. And, we really partner with a number of organizations, particularly around Cancer Screening Week, which is, as you guys know, it's coming up. And it's really important for us to take action. And we believe that when you do cancer screening, it really has a big impact in the community. And then we have our Lung Cancer Project. It's a movement to identify and understand and remove stigma and other barriers faced by people with lung cancer. As you guys know, a lot of people who actually, are at risk for lung cancer are sometimes a bit shy about coming forward to get screening. And so as a result of that, we partner with a number of organizations and have a number of resources to really help these patients and really urge them to come forward and screen sooner. Next slide, please. And so when we talk about lung cancer is the leading cause of cancer deaths. It's more than the next 3 cancers combined. As you can see here on the slide, when you look at breast cancer, pancreatic pancreatic cancer as well as colon cancer, the number of patients that deal with number of deaths associated with lung cancer is much more than all three of those combined. And so it really reinforces the reason why it's so important to address lung cancer, and to address it earlier. Next slide. Now, when you think about the potential of early detection of lung cancer, what percent survival after complete resection? And as you can look here, you're looking at 72 months. This really shows like how important it is to get lung screening, how important overall survival is. And so again, it just reinforces why it's important to identify these patients and identify them earlier. Next slide. Now, screening rates across prevalent solid tumors. And looking at this, against the recent guidelines, when we look at breast, we look at women from the ages of 50 to 74 who had mammograms in the last 2 years, you can see the rate is pretty high at 71.6%. And then when you look at cervical, it's 81% between women 21 to 65. And I won't go through all of these, but as you can see, as we go down the list of the top cancers, lung cancer, although it has the highest number of deaths, we're only at 5.9% of screening of screening rates. For that target group, which is 55 to 80. So as you can see here, we have a lot of work to do as it relates to lung cancer screening. Next slide. The National Lung Screening Trial and benefits of screening. Here, we really talk about the importance of screening. When you look at 53,000 patients who are high risk for lung cancer, 70% of those patients have been found to not have cancer. And so what this really is saying is that, where a lot of patients are afraid to come forward to actually get tested for cancer, 70% of those patients are actually found not to have actual lung cancer screening. And so it's just really reinforcement to really to really make patients comfortable about lung screening, and that their rates are typically low in terms of positivity. And then just, again, some of our resources we have is we want to really get the word out about Think Screen Know. It's really a campaign to drive awareness, education, and the benefits of lung cancer screening to HCPs and patients. And we actually have a Think Screen Know website. And so you can go to Think Screen Know. It shows all the different resources that we have to really help support your lung screening efforts. Okay. And that pretty much brings the end of my presentation. So thank you for the time today.
Tiffany, I know that we're keeping it really short. How do you do a lung screening? Like, how would an employer do one?
Yeah, so if you go back a couple of slides, basically here, right there. So yeah, so when you go back a couple of slides, usually it's pretty simple. You go in and get a chest x-ray and you get a CAT scan. And so it's really simple. I know a lot of patients are concerned about like how in-depth the lung screening is, but it's a really simple process. It doesn't take that long. And so it's really not anything for patients to be fearful of.
Okay. Good. That's very helpful. Thank you. Mm-hmm. So let's now let me introduce Lindy Wilson with the Cancer Treatment Centers of America, a center of excellence for cancer care. Tell us a little bit about CTCA. Lindy?
Yeah, I'd be happy to. Good afternoon, everyone. After employers experience decades of increasing costs for healthcare, with cancer, by the way, at the top of the list, combined with an uneven quality and patient experience, it actually became time for Cancer Treatment Centers of America to package our world-renowned quality and top patient experience for the benefit of employers in a direct-to-employer offering. Most of you have seen our commercials, but when we dig deeper, we find a recipe for outstanding patient outcomes and a patient experience that is unsurpassed. And it's also validated by external organizations, and providing long-term savings and cost control for employers. We are the only national comprehensive cancer care network. This is critical if an employer is multi-regional, where patients are seen by all specialists on the same day. And by the way, not only are patients seen by all specialists on the same day, but our average time to appointment is 5 days, and the industry's average time to appointment is actually 27 days. All of this are contributors to our #1 provider brand, as well as our top class patient satisfaction scores. And this is critical because we know that an engaged patient is one that actively engages in wellness activities and also, once diagnosed, follows a care plan, both of which are critical for optimal outcomes. Next slide, I guess I can't advance it.
Michelle, can you advance to the next slide, please? Well, I think we skipped a few.
Yeah, we're on,
yeah,
thank you. Most of you, excuse me, to be effective, not only is the patient engaged, as I mentioned, but that engagement has to be easy for them. And it has to span all of the patient's needs. Patients that have to miss work often to attend appointments on multiple days and locations have increased levels of stress and frustration. And of course, this is not positive for healing. Related to healing, let me take a moment to describe our touchstone, which is called the Mother Standard of Care. Mother Standard is how we treat every patient. We treat them as you would treat your own mother, and we take this very seriously. And we also, this Mother Standard is evidenced in everyone from Dr. Basu all the way down through the organization. We combine this with this high touch experience with precision and personalized medicine, which is specialized treatment based on genomics, clinical trials, which allow our patients access to the newest options for treatment, and continuous connection to patients, both in person and virtual, as well as using coaches and navigators. Next slide, please. And this is why we've been honored with some of the highest accolades in healthcare, propelling our brand to #1 in cancer care. Next slide. Matching the capabilities of an academic center, but enhancing the patient experience and engaging them from diagnosis to survivorship, and all through the changes of post-cancer treatment, is also a significant impact to the employer. Employers also tell us the care and experience received actually has a halo effect on their provision of benefits. Next slide. Our goal is actually to transform care in both a scientific manner as well as a high touch manner, and to touch the lives of 1 million cancer patients. Next slide. Our employer program is divided into 4 categories. Each category has significant differentiators from other programs, including genomics, virtual care, coaching, partnering with other providers and health systems, cancer fighters, and others. Unique to our products is an employer carve-out with discounted care for our employer partners. Next slide. Also unique is our hub and spoke model with provider partners in many communities across the United States. We would welcome the opportunity to customize this for you. Thank you.
Thank you, Lindy, very, very much. Just a note about questions and answers and the chat box for our participants today. Lindy and Tiffany, there are a couple of questions that participants have asked about in the Q&A box, if you wouldn't mind typing in an answer for them, one for each of you. And there may be more, so keep an eye on that, please. And now we'll move right into the program. Oh, and all of those who are attending this, we do welcome your questions. We'll have ample time after Dr. Basu's presentation to address a lot of your questions, hopefully all of them. So please put those in the Q&A box, and I'll be reviewing those and asking Dr. Basu the questions after he speaks. Or you can put notes in the chat box, and and the speakers, and we'll have access to that as well. So let's move forward with the actual presentation, our keynote presentation. We're just so pleased to welcome Dr. Pat Basu. He's a nationally recognized cancer care expert, and he is going to give an overview of the lay of the land of cancer and cancer care as it relates to employer-sponsored cancer care. So he also is a well-known, he's got quite a pedigree in serving in many different capacities. You can see some of the information on his speaker bio, which is on the slide here. But he's quite renowned, quite knowledgeable, and I've had the pleasure of talking with him previously, but not the pleasure of meeting him in person. None of us have, so maybe that will happen in due time. So Dr. Basu, we are so pleased to have you, and I'll turn it over to you and your slides. Thank you very much for joining us today.
Well, thank you, Marianne. Thank you so much for having me. I appreciate it. I do love Dallas, and I'm sorry that I cannot that we cannot do this in person, but I applaud the effort of putting it together. Maybe to start off on a light note, I'm a huge football fan. I'm a Chicago Bears fan, but I did have a chance to catch the thrilling Cowboys comeback recently. That was quite the game. So congrats on that. And Marianne, I will definitely take you up on the offer. I look forward to coming out to Dallas and meeting you when things calm down. Along those lines, I know these are just incredibly unsettling times and challenging times across the board. So I hope that everybody in the audience is staying healthy and safe and well. And I really appreciate your participation today. As Marianne mentioned, I will go through a presentation, but please do record and submit any questions that you may have along the way. I really wanted to start off broad before we get down to it. And given that this is 2020, I want you to think of these 4 bullets. And since we're not live, you won't be able to kind of shout out the answers. But I want you to think in your mind about the nation that has the largest economy and the strongest currency, the most powerful military, which one has the largest political influence, which one is recognized as an educational and cultural center of the world. And if you think for a moment, maybe it's differing answers for each of those 4 bullets, maybe it's the same. We won't have you submit your responses, but just kind of hold that question, that answer in your mind. In 2019, when I was doing a lot more live speaking, I asked a similar question, and the audience would shout out a variety of answers. Some would say China, some might say Russia, some might say France for a couple of categories, or England, or India, or Brazil. The answer for all 4 of these, by quite a far margin, is the United States of America. And if you flash backwards, though, about 100 years, and you picture yourself, perhaps not on a Zoom call, but somewhere in London or elsewhere in the United Kingdom, the answer would have been the United Kingdom for many of these questions. At one point, that is a nation that held sway over 1/5 of the world's entire landmass, 1/4 of its population, an incredible influence on the world. But as we concluded World War I and sadly, began going into the Great Depression, change happened pretty quickly, for the United Kingdom, to the point where pretty soon these answers were no longer true for the United Kingdom. And so oftentimes, I wonder, 10 years from now, in the year 2030, not only what will the answer to these questions be, but what can we do as Americans, as citizens, as professionals, to ensure that? And if you pause on that question for a moment, probably a lot of things come to mind, particularly during these times. But one that doesn't get talked about enough is healthcare. And many of you are familiar with this, but the numbers just are so staggering that they sometimes just sort of wash over us. 19%, one out of every $5 of the American economy, the American GDP being spent on healthcare. Maybe it's right, maybe it's wrong, but we certainly know it's a lot. But what do we get in return for that? What is the value to us as Americans that we get for that investment? Sadly, from a quality and service perspective, it is by a large amount of metrics, not nearly good enough. 100,000 Americans killed every year due to medical error, the equivalent of an airplane crashing every single day. But we don't hear about that. From a service perspective, we're all too familiar with this. 3 weeks to get an appointment. You go out, you go there in paper, you fill out the same form that you filled out last time. You wait in the waiting room for a couple hours. It is certainly not the service we expect. And to double click a little bit more on quality, 1 out of 4 American hospitalizations end with a major error induced by medical cause. A staggering number if you think about it. 25%, 8 million of those hospital discharges. It's gotten so bad, or has remained so bad is probably the more accurate term, that medical error ranks as a top 3 cause of US mortality. And furthermore, with the perverse incentives that we have in the healthcare system, hospitals have tended to do better even when their performance was worse. To be clear, with rare and sad exception, I don't think that's intentional. I don't think many people choose this profession or otherwise intentionally doing that, but rather it is the way the system is geared. So many of you may remember a wonderful feat of technology that was rolled out in about the year 2013 or something, the Affordable Care Act website, a model of IT technology. That's me in my role building that website. No, I'm just kidding. I'm totally kidding. I had nothing to do with that. I hope you're smiling and laughing and knowing that's a total joke. I don't have any of those skills, to be clear, to build or design websites. But what I did opine on is submitting a strong recommendation and a memorandum that read the impact of U.S. healthcare on American global competitiveness and national security. And the thesis, without boring you, of that was that of all the things that we think about from a national security perspective, and let me be very clear, having worked at the White House, those are real threats. One that doesn't get talked about enough is what causes a lot of nations and empires to decline. It is breaking down from within. And the sheer fact of the matter is, no matter how you slice it, we can no longer continue to get the poor value out of healthcare that all of us invest in. Certainly employers high on that list, but we need to get greater return on investment, better quality, better service at lower cost. And so as we kind of start broad and we bring that really into today's discussion, how does that relate to oncology? I used to be a senior executive at United Health Group and Optum, and as you can tell, or as was listed there, having worked at the White House, both at Medicare and at United, and frankly across certainly almost all of your books, oncology is likely a top 3 area of cost. It really epitomizes the challenging, confusing access that fellow Americans go through to get care, irrespective of where they are on the spectrum, and sadly don't get the standardized, excellent, dependable quality that we must demand for all of our citizens and all of our employees. So let's look at a high level at cancer in numbers. Again, staggering. It is a highly prevalent disease. 1 in 3 Americans will be diagnosed with cancer during their lifetimes. I am so honored and fulfilled and passionate about my job and my work, but it is truly staggering how often I get a call or an email from somebody I know because sadly their family or friend was recently diagnosed. The numbers are incredible in the sense that 10 million people die every year from cancer, making it the #2 killer behind heart disease. A staggering number, which is something that we've made our life mission, my life mission, not only to build a better American healthcare system, but really to do everything we can to stop this horrible disease. As I mentioned, it is a great cause of rising economic cost. It is by a long shot the #1 cause of stop loss claims. And certainly we've made a difficult battle, to use that metaphor, even harder in the time of COVID, because of decreased screenings, because of disruptions in access, because of miscommunication or misinterpretation. Cancer diagnoses are down 30 or 37%. In the time of COVID, even though we know clinically, statistically, scientifically that clearly those cancers are not, they've not been reduced. So we're just simply, as a society, missing them right now. Cancer and images. The first picture there in the top left, sadly in the year 2020, we have been reminded in that case with COVID-19, with the virus, the singular power that a small, tiny organism or cell can have on our body. But cancer, again, is the epitome of this, right? It starts at this microscopic molecular level, and essentially uses the body's own systems to grow to the point of great demise. And as my colleague from Genentech mentioned, and we'll talk about, no question about it, catching it early is critical. The second slide there, lightning on a blue sky. As a physician, as a father, as a friend, when I meet people with cancer, which is sadly, all the time, it doesn't work the way many other healthcare diseases do, where there's a kind of a slow roll up to the event, right? Somebody's knee or their back hurts a little bit, then it hurts worse. Somebody starts to gain weight, and the conditions associated with obesity manifest themselves. Diabetes, hypertension, lung diseases. But with cancer, 99 times out of 100, when I talk to patients, it is lightning out of a blue sky. Just a devastating, singular, bolt that affects them, and it is frankly, again, as a physician, the single most biggest gut punch that I have dealt with and that I see on a daily basis. The picture there at the bottom left is the Battle of Troy, often regarded as this epic greatest battle in history. I would like to say, and I feel very passionate about this, that our greatest battle in history is cancer. This is the definition of an intergenerational struggle. We've been fighting this disease for decades. One could argue centuries or even millennia, depending on what it is. There's recent evidence that the dinosaurs even died of this condition. It is the battle of our lifetime. It doesn't pay attention to color or race or creed, what country or continent. It is a human battle that we have to win, and winning it is a battle of body, mind, and spirit. Again, unlike I'm recovering from recent tendon surgery. In that case, it was sort of a finite event. It was one-time surgery. Yes, did some PT, but back in action. Whereas cancer, again, taking care of patients, talking to patients, it is a battle of the mind and the spirit as much as it is the body. And so finding ways to deliver care management, care navigation, support services making sure that we allow those patients to continue their battle and support them is paramount to success. More important than cancer in numbers or cancer in images is this aspect. Linda Wilson mentioned it. It is our mantra. It is our creed. It is why I and my colleagues work here. The mother standard of care. And one of our mottos that we live by is, it is always and only about the patient. It's hard not to get emotional when I, having met some of the people on this page, and I think about their stories, from the woman in the middle who was told not only she wouldn't ever live, and then when she was showing signs of recovery, she went back to her doctor, and that same doctor said she would never conceive, and yet she had a baby. Others that were told, get your affairs in order, and they were able to enjoy another grandson being born, a granddaughter going to college, a daughter being married. The stories are incredible, and they give me tremendous inspiration and hope and passion. So with that, and in the remainder of the time, I want to just take you on a journey that I hope you will find informative, educational, and action-oriented to things you should look for in a cancer program. Cancer care in the US today. Let's start with some incredibly positive news. Again, thanks to wonderful provider organizations and to partners such as life sciences partners, we've made incredible strides against this horrible disease. Between the 70s and the early 2000s, you can see how much cancer survival rates improved. All cancers during that period going from 50% to 67%. Yet you can certainly see that there are certain cancers, as was mentioned, lung among them, where we clearly need to improve that battle, not only with better therapies, but with better care delivery, earlier screening, prevention. But the bottom line is we've made great strides, and you can mark my words, this will be the decade of cancer progress. We are making incredible, incredible strides. One of the results of that is that we are aiming to cure this horrible disease, but in the process of that, we're at least trying to convert it more into a chronic disease. The number of people living with cancer is rising dramatically, as you can see here, with 20 million Americans now living with a prior history of cancer. So that is a very, very positive thing. Make no mistake about it, because those are patients who would not have seen their daughter's wedding or their grandson being born, or some of those stories that I have the privilege of hearing without it. The consequence for all of us on this WebEx is what that means from a care delivery perspective, what that means for us as stewards of their healthcare. And as employers, if you look at that number, nearly half of that population is between the ages of 20 and 65. So the likelihood now and in the next, and I'm sorry, I misspoke, that 20 million is 2026. The number right now is about 18 million. But you're talking about a huge amount of folks that have a different set of needs because of their prior diagnosis of cancer. As we mentioned before, the spend on cancer expected to rise from 180 billion in 2015 to 250 billion at a 34% increase in the years ahead. And the consequences that has, again, you look at macro level data and it's easy for the numbers to wash over us, but if you look at this at an individual level, you can see that the average monthly income of an American citizen is far lower or lighter on this scale than the heavy costs of cancer therapy. 1,000 to 12,000 on the chemotherapy, 9,000 or higher on the radiation. Obviously, there's surgical costs that are not listed. And as Marianne mentioned at the beginning, some of these treatments can be very expensive. Now, I want to be clear that many of these treatments can also be very, very life-saving. Many of these treatments have actually contributed greatly to that increase in mortality improvement. However, as with other aspects of healthcare, we need to find ways to deliver those in a cost-conscious, cost-effective manner. Because the burden on patients is tremendous. What you're looking at here on the graph to the left is the probability of bankruptcy. The varying color is showing years 1, 2, and 5 after diagnosis. And you can see the, the significant percentage of patients who are devastated financially. Off to the right, you can see, nearly half of the patients by the second year have exhausted their savings and their assets, and a far greater likelihood to be bankrupt as a result of their battle with cancer. And yet, as my colleague, again from Genentech, mentioned, and I'll tell you about morbidity in a moment, we have powerful methods to protect against this and have a much better outcome. One of which is absolutely early detection and screening. And you can see that on the cost side, the incredible dollars saved when you catch things earlier versus later. And so this just absolutely has to be something that even in the time of COVID, we have to find ways to get each of these patients screened and catch this horrible disease earlier. In addition to cost, as I mentioned, we face an incredible challenge in access across the spectrum. If you look at kind of those three broad categories, this is a confusing, scary, heart-wrenching disease, irrespective of which of these buckets you're in. Think for a moment right now of a patient. Maybe it's a woman, maybe she's 32 years old, and she knows that she has a family history of cancer. She's seen on the news, or she's heard that Angelina Jolie had a double mastectomy. On the other hand, she's wondering, confusing guidelines, should she go in and get a mammogram? It's a bear for her to deal with that. And it's not just student body left or student body right. It is a risk stratification methodology, a precision, personalized plan in every one of these cases, because you can't just have everybody go off and just get double mastectomies. You also can't have people just ignore this disease and catch it. So you really need a tailored program at every element. You go to the acute side, the 1.8 million new diagnoses, you'll see tremendous variation in outcomes and satisfaction of the moment. And again, the same thing on the prevention side, cancer survivorship. On one hand, you don't want somebody who had a prior history of cancer to get a cough or some symptom, go into the ER, and the ER orders a battery of tests, which leads to a bunch of other, false positives and the like. At the same time, certain conditions, a recurrence of a primary tumor, a likelihood of a secondary tumor, are things that the keen eye, or rather the sophisticated, the sophisticated cancer provider can pick up that a general hospital, could not. And so really, really important that we get this right. More important than the dollars is the human element of this. And the numbers are simply staggering when it comes to early detection. You look at prostate cancer. Essentially, you catch it in stage 1, 100% likelihood of survival versus 28. For ovarian, 92 versus 27. Breast, 99 versus 24 across the board. And even for lung, greater than 50% chance, catching it early. Our chief medical officer, Dr. Schenk, has a saying, in cancer, waiting is suffering. And we agree. We see that from the human element. But it also has manifestations in terms of real clinical outcomes. Cancer, not just in terms of catching it early, but once a diagnosis is made, is treating it early is important. Now, to be clear, we're not talking emergent per se. You don't need to rush somebody to the hospital and do the wrong thing. But when Linda mentioned the average being 28 days, and we see that, in fact, we see referrals or other peer institutions where it's 40 days, 50 days. You see one doctor, 2 weeks later, you see the next doctor, 3 weeks later, you see another doctor, and then 6 weeks later, you're actually working on a diagnostic and treatment plan is unacceptable, because you can see that time to treatment is important, not just emotionally, but in terms of actual reduction in mortality. But as much of the healthcare system is kind of a culprit in other areas of medicine, from diabetes to to heart disease, the same is true here. You can see that despite the overwhelming evidence on life-saving screening as well as cost-saving, you can see the number of the eligible population that doesn't adhere. 38% for colon cancer. By the way, I think my colleague from Genentech would agree that this study probably underestimated the lung CT scan at 26%, because that's one where certainly we need to improve as a society. It's gotten a lot more challenging, as I mentioned, during COVID. The main ways that people often get their diagnosis is through a dedicated screening program or through what's called an incidental finding. You go in for some other procedure or perhaps some non-specific symptom, and the cancer gets diagnosed. A, because patients are missing their screenings, and B, because they're not kind of interacting with the healthcare system as much. Screenings are way down. By June or July of this year, so not even updated, it was about 22 million Americans had missed their cancer screening. And it's resulted in at least 80,000 missed or delayed diagnoses. And sadly, those diagnoses will then manifest themselves later in the cancer curve with, sadly, worse outcomes for those patients. And all of this comes together intrinsically to impact the quality of care in a fragmented fashion, as well as the thing that characterizes so much of American healthcare: broad disparity, and just a system that sadly does not have right diagnosis, right time, or first time, every time. And certain studies estimate that 1 out of 5 cancers were misclassified. 40,000 cancer patients died because of a misdiagnosis or delayed diagnosis. There is, as I said before, a microcosm of American healthcare. Too much variance, too much disparity in American healthcare quality. The same is true in cancer. Because of a program of excellence, we get a lot of patients who come to us second opinion or come to us after failing treatment somewhere else. And so often, we see that a place may have done the right broad textbook therapy, but it wasn't the optimal tailored therapy, for that patient. And it's very sad to see as you hear these stories. And so we have to do a better job of getting patients to the right care right away the first time. This is just evidence. CTCA is an example in the light blue bars here. You can see even though these are SEER national NCI data, not just the random oncology shop on the corner, there's still significant variation in outcomes. Standardized third-party published outcomes. And my goal is to have all of these numbers be the same, the light blue bar and the dark blue bar, to all be as close to 100 as possible and not have the gap between them, because that would mean that as a nation, we have reduced that variance and gotten our fellow citizens, our fellow mothers, fathers, sons and daughters, the care that they need. The right side of this page is equally important. Again, unlike the surgery that I recently had, in cancer, the right side of this page helps drive the left side of the page. What do I mean by that? Again, imagine a patient who is in the battle of their lives, 3 months into it, and they've had chemo or radiation after surgery, previously, and they're wondering whether they should go on. They're wondering whether they should stick with their treatment. They're in pain, or they are, just anxiety or upset. We can't have them quit, right? We can't decrease adherence to their therapy, which will reduce their outcomes, reduce their quality, reduce their survival. So it's not just a buzzword in cancer. In healthcare, there's a lot of, well, let's manage, care management, let's make sure we get to the patient. Yes, but is that really happening? Lots of evidence shows, my time in Optum, that's not. But in cancer, the reason we take this so seriously is not only is it the right thing to do, not only does it make a patient feel better, it allows them to continue their treatment and end up in the light blue graphs on the left side of the page. So with that, what are some things that are specifically impacting employers? I think this slide does a decent job of summing up a few of the categories. When an employee gets cancer, they are obviously, it's going to affect their work hours, it's going to affect earnings, it's going to affect every aspect of their emotional and financial well-being. It is a devastating impact on the human being, and as a result on those around them. As you can see here, the impact on caregivers is tremendous, and so it is a truly devastating event that needs the same level of attention that we give to diabetic programs, maternal programs, kind of anti-obesity programs. The same needs to be done for cancer. From a cost perspective, as I mentioned before, both from Medicare and both from my time at United, I know it's a top 3 driver. Statistically speaking, cancer represents about 12% of annual employer costs, which is a large number to start with. And you can see some of the staggering numbers there on the right. Really significant. 5% of employees will have a history of cancer, a very high incidence of new cases per 100,000. As I mentioned before, not only a large cause of stop loss, but a large cause of long-term disability. If you look at the high cost claims specifically, and it's actually unfortunate that this was broken out this way, because really malignant neoplasm plus leukemia, lymphoma, and multiple myeloma, if you really add those together, the 8 to the 19, you get about 27% of those cases that are in that high cost claim condition. And so tremendous outlier in terms of the tremendous outlier in terms of the number of cases that cancer represents there, and a huge impact on any risk-bearing entity, whether it's an employer, a risk-bearing entity payer, or a risk-bearing entity provider. Sorry. And so what are some things in conclusion that you should really look for in an employer program? 5 tenets, you remember at the beginning I showed that slide that showed the tremendous progress in cancer in the decades previous. And I boldly and confidently said that this is going to be the decade ahead, not just because of the advancements in science, which by the way are tremendous. What we're doing in medicine with precision medicine and data is absolutely going to save lives. But too often in healthcare, we focus on what I call the y-axis, the new treatment, the new stent, the new imaging, hugely important. But we sometimes forget about the x-axis, which is the care delivery, the workflow, the behavior modifications, all of those things. So number 1, stop it or catch it early. Huge statistic. 50% of cancers are preventable. Massive number, right? If you were to ask most Americans, is diabetes preventable? Is obesity preventable? Even heart disease? Most Americans have been educated on that. You ask most people if cancer is? No, they think it's a inevitable thing that's going to happen to them. Either the cell is waiting for them in the body, or there's something in the environment or something that they're going to do. They don't think about the things that we can do to prevent it. What I like about a cancer prevention program is its manifestation on other disease programs that you might have, whether it be diabetes or obesity. It works in that direction. But you and I both know that you tell a patient, don't eat that Twinkie because you might get obesity or you might get diabetes. Sometimes it works, and most of the time it doesn't. You tell them it might cause cancer, and it has a powerful effect. I know that statistically, I know that as a clinician. If you can't prevent it, then catch it early, as we talked about before. Diagnose it correctly. I sometimes say that when I first began medical school, there were 12 types of cancers by their organ. I now say that there's 12,000 types of cancers, because with precision medicine now, we not only know that it's breast cancer or lung cancer, but we might know the specific mutation that is causing it. So if you miss that, then you're not going to get the right treatment. If you catch that comprehensively, now you're not just treating the organ system, you're treating the underlying mutation, which makes all the difference. Again, treat it quickly. Waiting is suffering, and we know that the longer you wait, the worse chance you have, which, by the way, if you just think about it, makes sense, right? If disease progression and cancer growth traverses from this stage to this stage, then just like a number crossing the x-axis at some point, that tumor is growing. At some point, it's metastasizing, right? So no, do you need to rush somebody to the hospital? No, in fact, you shouldn't, so they don't make a mistake. But you don't want to sit on that therapy for the weeks that we sadly see happens. At the same time, treat it appropriately. American healthcare is full of false choices. Frankly, right now, I think American society is full of false choices. It's not a false choice. We can treat it quickly and treat it appropriately. It just requires a focus factory of attention to really get after that diagnosis and get the treatment plan. Finish the treatment, comprehensively. Don't have disruptions in care. Don't have reasons why people don't have medication adherence or radiation adherence. So sounds easy, but what does that mean? Have to have the care management programs. Have to treat those symptoms. This is a brutal disease. I'll give you a quick example. We have nurses that focus on sexual side effects. Most, having worked as an executive at an insurance firm, most people would say, well, do you really need that person? Well, maybe in other areas you don't. In cancer, where a sexual side effect is one of the top 3 side effects of any cancer, not just urologic or gynecologic, you don't want patients to have a side effect stop them from continuing their treatment. It's a waste of treatment. It's a bad outcome. So cancer has a special set of circumstances that require us to focus on getting them to finish that treatment. And then if, and hopefully when, knock on wood, we turn it into a chronic disease, and for those cases that already are, have to manage that chronic disease. Have to have the appropriate surveillance, not too much, not too little. So, as it relates to programs, what are some ways to address this? Have a population prevention and screening program. Just like you would for, again, heart disease, obesity, diabetes, we have to put these in place. It's powerful. It makes a difference. Again, to both diagnosing it correctly and treating it quickly and appropriately, have to have an excellent hub partner and a hub and spoke model. I'm a giant believer in American healthcare. Get therapy close to home, makes it easier, makes it conducive, facilitate that. But boy, oh boy, at the beginning for the diagnosis, for the treatment, have an excellent hub, and then have that hub work with those spokes. So what does that exactly mean? It means, for us, we want to work with the local primary care doctor, work with the local oncologist, work with the local hospital to ensure that a patient just can go 10 minutes down the street, but that they're getting the right care and the right therapy and the right diagnosis. Finishing the treatment is partly having those local partnerships folks, right? You don't want people to, let's take our example. If somebody's not close, we want to find a local partner so that it's not a pain for them to have to, come to us if we're not close by. But at the same time, you have to manage that whole person care. The behavioral and social determinants of health here are critical. You don't want patients to not pick up a medication because of cost. You don't want patients to not continue a therapy because of side effects. And then finally, on the chronic disease side, as I mentioned before, if half of those 18 million are between the ages of 22 and 65, really need programs that pay specific attention to those that have a pre-existing diagnosis of cancer or a recently treated diagnosis of cancer. Coordinated care cannot be overemphasized. If you look at the kind of the spectrum of these kind of 6 boxes at the top, every one of those nodes has a potential for a breakdown. And in every one of those cases, I have seen during my time in my career areas where that does break down. These care gaps need to be closed. Those handoffs need to be done with surgical precision. I love healthcare. I love the profession, but we're one of the only ones where, you know, we're still asking for doing things from a care delivery program that you know, most industries started doing 15 years ago. As I sometimes say, prior to United, I'd started a company called Doctor on Demand, a large telehealth company. But I sometimes say, you know, hopefully I look forward to the day when we don't call it telehealth, just like we don't call it telebanking. We need to insert technology, common technology that is powerful at every phase. We've made major groundbreaking strides at CTCA with this. Really taking all of our comprehensive care, all of that whole person care that we're known for, from the cutting edge doctor to the nutritionist to the cancer coach, putting them into the digital virtual care environment, but also really using this to monitor care gaps and do care coordination. So in your employer programs, definitely partner with those who are using technology in the right way. And work with partners who can really, in a data-driven manner, in an actuarial fashion, monitor quality and cost. I can tell you this is not easy, and you can imagine it's not fun. No offense to any actuaries out there, but not high on the list of the most fun dinner conversations, but it is important. You know, we've invested a great deal of time and frankly dollars into understanding these, you know, episodic treatment groupers, knowing for a given type of cancer where those costs occur, why they occur, did they need to occur, and really focusing on total cost of care to monitor and bend that cost curve. That comes not only from the actuarial side, but it comes from the clinical care model side. In this journey of a patient named Susan, just watching her go through the nodes, we know the big area, because taking downside risk, doing total cost of care, it requires knowledge and focus, because you want to do everything for everyone all the time, but the reality is you need to know where those major changes are. Let me kind of highlight this one right here. 30%, if you think about a potentially $150,000 cancer case, 30% of that number, could absolutely be saved from deviation from an evidence-based pathway, right? You tack on another 20,000 due to poor, care coordination, care navigation, and you're talking about a huge amount of costs. If it's been estimated that $900 billion of American healthcare out of that 3.5 trillion is due to inefficiencies of waste and abuse and other forms of inefficiency, there's no question that oncology at the tip of the spear is a part of that, where we can squeeze that waste out of the system. And so in conclusion, as I open it up to questions here, looks like right on time to do the Q&A. What I would say is the time is absolutely now. As those dinosaurs are looking over there at the ark, let's make sure that is not us. The time is now. I'm telling you, from a decade of cancer, much like what happened with cardiac care, I think in the 90s and early 2000s, we are going through a renaissance in cancer care, not just on the cutting edge therapies, which by the way are incredible, and the cutting edge diagnoses, which are equally powerful, but in the care model, in the idea that just like we would focus on the prevention of heart disease and the post-acute care, we have to give that same level of attention to the prevention of cancer and the post-acute care, in addition to the correct diagnosis and the correct therapy within cancer. So an important time ahead. As in every single aspect of healthcare, employers play that critical role. Not only are employers the underwriters of American healthcare, they are the stewards of it, of taking care of employees, making sure they are not falling through the cracks, not sitting around waiting in waiting rooms and getting yanked around, but being cared for with high satisfaction. And so the time is now. Work with thought partners to deliver high quality, cost-effective care. And with that, Marianne, I am happy to turn it back over to you. And if there's any questions, I'd be delighted to try and answer them.
Yeah, this is just really, really good, and you're getting accolades from those who attended too, and you, mine included. So a few questions have come in, and if you look at the chat box or in the Q&A, you can see the answers. But one of the things that you mentioned, Dr. Basu, is about the misdiagnosis or misclassification, and the number of cases that are indeed that case. And I've read numbers like that in some of the materials that we've been reviewing here. So I guess, could you speak a little bit, you mentioned second opinions, but you didn't go into detail on precision medicine. And that's one of the things that we've been talking to our employers about is the absolute imperativeness of getting the right medications or the right treatment. And you mentioned getting the appropriate treatment is critical. So can you mention
Absolutely.
And is it costly, and what happens with that?
Definitely. So maybe let's kind of work kind of high to more specific here. So getting that right treatment at the beginning, so critical. And American healthcare is fraught with what I call the difference between perception and reality. Let me give, well, I won't mention any names, but I've had the privilege of working or being faculty at a lot of great places that are great in certain things, but just because there's a billboard in center field, we think they're great at everything. They're not. They're just simply not, right? And there are bad doctors, bad outcomes, bad procedures at all of these places. Variation is the enemy of quality. And so we have to get that right diagnosis at the right time. We've had patients come to us from phenomenal institutions, and we say, oh, they didn't do this. They didn't do this precision medicine workup. So what is that? Let's first talk about kind of personalized care. Personalized care to me is the superset of which precision medicine is kind of one subset. Personalized care is the idea that you know, Marianne and I, you know, we might require different doses of things. We might require different therapies based on genetics and age and other, you know, factors. And so a treatment plan needs to be grounded in evidence, but it needs to be personalized. And precision medicine is the scientific sort of pillar of that, draws on some important points in cancer care therapy. There are genes in our body, in our germline, as well as in the tumor itself. Imagine for a moment a tumor that has, you guys have all been seeing the cell picture all too often because of COVID, but you see the spikes, those little proteins kind of sticking off the cells and things, or off the viruses. Cells have those, and they're receptors. And you can imagine a sphere that has 10, 100, or 1,000 receptors of a certain type. Well, geez, if we notice that cell has more receptors of a certain type, that might mean that we can be more efficacious in a certain therapy that bonds to it. Or if we can pinpoint that tumor has a lot of mutations, we have a different therapy that we would choose to target that cell. Think of, instead of a carpet bombing, to stick with the war analogy, we are doing laser guided precision therapy. It's a sniper approach instead of a shotgun approach. So precision medicine really is a diagnostic comprehensive workup that quickly ascertains what are the profiles of this tumor in relation to this patient's body that might cause us to say, boy, we would normally reach for this pathway off of the shelf. And 9 times out of 10, that's what would happen if you go somewhere else. But at places that are thinking like this, they're going to say, oh, in this particular case, in those 10%, this is the therapy that we need to use, and it can be life-saving and cost-saving. So that's kind. And so how do you legislate that? Unlike primary care, diabetes, or medicine, which is here, even radiology and cardiology, which is here, cancer is one of those tough ones to get your arms around, right? You guys are wonderful HR professionals, but you're not going to go hire an army of oncologists to say, geez, what's the precision medicine pathway here? So you need to work with trusted partners. And I intentionally use the word partner because this shouldn't just be a total outsourcing to them. They should work with you to design the right program, for your needs. But Marianne, without a doubt, precision medicine and that aspect is critical to getting the diagnosis right in an increasing majority of cases.
Mm-hmm. There were several questions in the first stages, the prevention and early detection, and I really appreciate your comments about the amazing differences not only in the mortality rates but also in the cost by catching it early. I'm thinking about COVID, and I've read some statistics about 80% drop in mammograms, and I can't remember what it was in colonoscopies and so on. I don't know what about lung cancer screenings, but thinking about the dramatic drop in the screenings alone, and so many people are working from home, so even if you offered it, some kinds of screenings that work, the mammogram machine driving up in a big truck type of thing to the campus. What is the? I mean, are employers to expect a huge hit next year? With people who have not had the opportunity to have the early diagnosis, to not get their tests done, or delayed treatment because of COVID?
Yeah, question of the year. It is, I made this, because we keep using the metaphors of war, people said the war on COVID, the battle against cancer. I've told people, look, if you hearken back to World War II, we didn't say, well, we only need to fight in the European theater or the Pacific theater. We need to fight both. Similarly, yes, COVID is a very, very serious illness, but cancer is the definition of a prevalent, highly fatal disease that will kill 10 million people in the world this year, and several hundred thousand, 600,000 or more in the U.S. So we have to do both, but we have to do it in an intelligent fashion. And what's happening right now is patients are they're being rebuffed, repelled, or thwarted in a myriad of ways. One way is they want to get in, but the American healthcare system has never been known for being easy, and they can't get in. It's a real pain, scheduling, the doctor's office closed down, they didn't realize they had to get a COVID test, so they miss it. Another way is just confusion. They've been told due to some release that something's closed or whatever. And then another category is just legitimate fear. Boy, do I want to go in? So the first thing we need to do is kind of diagnose and understand what's going on there. And then, yes, employers can play a critical role in helping that, a safe, socially distanced way where you do a screening day, a way where you let people know, hey, is there anything we can do to help navigate to make sure that you get to a place that can do your screening in a safe, effective manner, where the clinicians have social distancing, where they're screening people, where everyone's, appropriately, masked and gloved. And then, Marianne, to answer your question, here's what I'm trying to do. I've written about a topic that I call the shadow curve, which is this idea that as we've been trying to bend the curve on COVID, there is a tidal wave rising, a shadow tidal wave rising of all the stuff that's kind of been piling up in the background. And I pray that there is not a study that comes out 3 years from now that says this many more people died of cancer, this many more people got stage 3 and stage 4 because millions of people were falling through the cracks. So I'm an optimistic guy, and so I don't want to say that that's going to happen for employers next year, but what I do want to say is I want to be a part of the solution trying to stop that from happening. So this is why we just all need to lock arms together and say, how do we risk stratify and identify those patients who have missed their screenings, get them in a safe, appropriate way to get screened, catching it at stage 1, versus stage 4. It could be not only the difference between life and death, it could be the difference between, yes, you still lived, but you were better 6 months from now instead of 3 years from now after, exhaustive therapy. So we've got to catch it early.
Mhm. I so agree with you on that. You also mentioned about in fact, you showed the cancer care journey, which I really, I forget her name, Susan, or the 68-year-old woman who had cancer. And it was good to see the coordination on the care side, the treatment side. But a lot of employers, in fact, most employers are interested in coordination on a larger level. And we talked about this last year in our Cancer Care Huddle theatrical presentation that we gave, where we brought together the whole team, more than just the medical team. The primary care physician has to be involved, of course, and you mentioned that. But the mental health, behavioral health professionals need to be part of this because of the anxiety, stress, depression, and everything else that goes with a cancer diagnosis. The PBM, specialty PBM, if it's managing it outside of the medical benefit, the disability insurance agent, the EAP, and all of these other services that are critical to helping the patient on the cancer care journey. How does a center of excellence, such as CTCA or any other center of excellence or any coordinated treatment side, how can that work with form a cancer care huddle type of thing, so to speak?
Yeah. Absolutely paramount. So let me give you maybe a few dimensions to think about. First is absolutely recognizing that as an issue is critical. Healthcare has, for too long, it's been too siloed, too insular, we're going to do everything by ourselves instead of partner and know, kind of what our roles are and how to do it. So we have to do it in a way that, let me use distance first. A program of excellence, a top tier kind of hub model is great initially because you want to get the right diagnosis, you want to get the right treatment, you want to get on the right pathway. But look, if a patient's coming from Seattle, I'd love to take care of them, but they should come to us for their surgery and their diagnosis and their precision medicine, get that going. And then they should go back to Seattle and work, 5 miles from their house, where we can coordinate with their primary care physician and say, the patient had immunotherapy, cutting edge medication. One aspect of side effects that you should be on the lookout for is this. If that patient has that, let us know, right? And we're also going to use technology to coordinate with them. But if they have a side effect, we may not necessarily have to, bring them all the way back to CTCA. We'll coordinate with you, Dr. Smith, Dr. Jones, and we'll work with you to manage that. That is how great care needs to be delivered in this kind of hub and spoke model. We actively look to employers to say, hey, who are some of those folks locally that you'd like to work with? And for multi-regional employers, pick a handful. We'll reach out to them in advance and we'll say, hey, we're going to be caring for these patients. Can we set up a WebEx with you to kind of go over a care coordination plan to do that? It's hugely critical. The final aspect is technology. I'm not going to say, satellite programming, crazy futuristic technology. I'm just saying using, modern technology to have patients like our CTCA Anywhere app, log your symptoms, let us know, we can trigger things. In today's technology, when used appropriately with a local coordination partner, that gives us a 360-degree view, 24/7 by 365 days, to at least monitor the patient, stop them from sadly having to run off to an ER or somewhere else, get them, a fever in a cancer patient can be, on one hand, life and death. On the other hand, it could just be fever. And our coordination with the local provider is the way to do that, as opposed to just having that patient, run off and call urgent care or call, somebody else. So happy to do a deeper dive with any of your members who want to kind of talk specifically about care coordination.
Right. This has been an incredibly informative and interesting presentation, Dr. Basu. I so thank you for doing this for us, and we're so pleased. We're coming to the end of the session. Again, I will remind all of our participants, thank you for joining in, zooming in, I should say, today. We will have recordings available to you, which we will send a link out later, probably in a week. The other thing I want to remind you is that we have workshop 1 and 2 on prevention and on innovative coordinated care models, which will take place on October 15th in the morning. And we'll take a deeper dive into all of the things that Dr. Basu talked about today and the questions that you've asked. And workshop 3 will take place on November 17th on caregiving, survivorship, and return to work, which is an area that we did not have a lot of time to touch on today, but we will definitely be taking a deeper dive into that. All of you are registered for the workshops 1, 2, and 3. Please mark your calendars. We'll make sure that you get reminders. And again, I thank our sponsors for supporting this very informative program. Go back and check your plans. Make sure you cover those lung screenings, or your plans do, and check on some of the other things that we talked about today. Thank you again for joining us, and Dr. Basu, great thanks to you for talking about this and teaching us some good stuff.
Thank you for having me.
Great rest of the day. Goodbye now.
Take care. Thank you so much.
Thank you.